Hello, everybody. We're going to go ahead and get started. Melody was unable to call in, so we've got her on the phone here, and she's our cardiac fellow. The COCATS 4 ACGME requires that cardiac fellows be interactive in the conferences for credit means for ACGME. So anyway, we've got her interactive. So we're going to start on our mystery case here, and we'll get our slides going. And so starting out, we have a very interesting patient who's 56-year-old female who basically, I have her medical records from 2001. And at that time, she presented to the emergency room at Largo Medical Clinic with palpitations, shortness of breath, chest heaviness. She had been to a wedding and basically had some problems with the bride. She became ill, took the bride to the hospital, and then she started feeling bad. And so she had intermittent palpitations in the past, negative prior cardiac workup, including a SPECT scan that was negative. There was some apical thinning, and that's all they found. And so here she was again at this presentation, and she had AV nodal reentry tachycardia, where her heart rate was 185 with narrow QRS complexes, and RP was shorter than PR, and she had some abnormal T waves across the precordium. Basically, she broke spontaneously, but she remained in the hospital, and she had a left heart cath. And it was really interesting because they said there was an area of septal and lateral akinesis that was a very discrete area. Everything else was normal, and they didn't know what was going on there, and they thought, well, maybe there's some little infarcts, one on each side of the heart, from coronary spasm. And so because of that, in those days, they would do ergonovine testing by injecting ergonovine and having nitroglycerin available to inject in the coronaries if there was coronary spasm. And so that was a popular test once upon a time for spasm. I don't think it's available anymore. So basically, mildly elevated troponin, abnormal EKG, resulted in the cardiac cath. I suspect the troponin was elevated mildly because of her supraventricular arrhythmia. It's a very common reason, which they call type 2 cardiac troponin elevation, which are non-specific, not related to STEMI or non-STEMI. And so it was a type 2 elevation, very frequent with rapid ventricular response arrhythmias. She was treated for a vasospasm, and she also had a transthoracic echo and was started on some medications, but she's very sensitive to medications, as most doctors and nurses are, and she's a retired nurse, and she was very, very sensitive to medication. We couldn't actually continue her medications. I did not see her. She presented again another time to another hospital, and this time she had some discomfort, no PND orthopnea, negative troponin, T-wave inversion again, chest x-ray didn't show much, and she had, they checked her for pulmonary emboli, and she didn't have that. She wound up getting another cardiac cath. This is at Lakeland Hospital, and this cath showed some LV dysfunction. Again, two discrete areas of anterolateral and inferior wall hypokinesis, some mild mitral regurgitation, normal coronaries, elevated PA pressure. You can see that should be about 35 at 51/23, and the V wave was actually higher than the A wave, and the V wave was 36. And so they thought she had mitral regurgitation, thought it might be related to these areas of left ventricular dysfunction. Her RV systolic pressure was okay this time. It was down to 23 on the echo, but was 51 on the pulmonary pressure. And so that would actually take precedence. The pulmonary pressure would trump the echo finding. And the TE showed a couple jets of MR, but it looked like it was only mild to moderate. And so she also was treated with Imdura, lisinopril, topril, Zocor, Elavil, Acifex, aspirin, nitroglycerin, PRN. And again, because of two distinct areas of LV dysfunction, it was thought that she could have maybe emboli to two separate coronary vessels, which would be perhaps the right coronary artery and perhaps the diagonal or LAD, or else areas of spasm that resulted in two very discrete infarcts in two separate areas. And so she was seeing cardiologists and being treated, and at some point became dissatisfied and decided to establish with a new cardiologist. And this is the first time I saw her was in 2004 with shortness of breath, palpitations, headaches, fatigue, and I'm not sure how much of this was from her medications because she's on some nitroglycerin once in a while. She was on some Iserdil for a while. So I'm not sure how much of this was her medications and how much was basically her problems that she had. And so when I saw her, there was some hypertension, hyperlipidemia, a heart murmur at the apex, radiating to the axilla, question about vasospasm, certainly AV nodal reentry tachycardia, and I think I had one of the EKGs, migraine headaches, status post-hysterectomy, drinks a little wine now and then, no alcohol use other than that, no illicit drug use. Interesting, her brother actually had sudden death at age 54. Father had a stroke and committed suicide. I don't know if that was because he had depression post-stroke and if it was organic or if he had had previous depression. And so, but there is a mother with heart disease as well, unknown. And so this is very interesting in terms of family history. When I saw her, this would explain her headache. She's on Endure 30, which certainly gives headaches to a lot of people. Aspirin for the headache, R for perhaps if she had bilateral coronary emboli, Coreg, minimal dose, Zocor. I'm not sure why she's on Zocor. She's got normal coronaries, and she's on Zocor. You'll have to explain that to me. Premarin, 0.625, multivitamins. And so her physical examination, basically the murmur at the apex, that wasn't very loud, and that's all we found on her physical exam. No S3. And here's your EKG. And basically what we're seeing here, and actually you can see somebody's written on the EKG to show what the T wave should look like. And we've got T wave inversion of V1 and V2. The complexes appear to be fairly narrow, and the PR interval is a little longish, but there's no first degree AV block. And so all we have is just some T wave in V1 and V2, which could be a normal variant, and normal QRS, and that's about it. Maybe a little prolongation of the QRS, but not much. And so careful review of her medical records brought up these questions. And the two opposite areas of akinesis, anterior lateral and mid-inferior wall, in the cardiac cath, both at Largo and at Lakeland, was very interesting. Never heard anything like that. Two separate areas with negative ergonovine testing for a spasm. Sort of blew the story about spasm because it's 95% positive response for coronary spasm with ergonovine. And so these lesions did not involve the papillary muscle, but were just in front of the papillary muscle. But that certainly could cause some remodeling of the left ventricle, and which could be responsible for some mitral regurgitation because the papillary muscles then may not be aligned properly, and they lose their alignment, causing mitral regurgitation, elevating pulmonary capillary wedge pressure, raising the right ventricular systolic pressure, all of that relating to misalignment of the papillary muscle due to remodeling due to these two areas. So the only other thing that came up is someone suggested that she did have an automobile accident, had a seatbelt, and they were suggesting a contra coup injury, which with sudden deceleration, forward motion, and then backward motion of the heart, resulting in a contra coup injury with the left ventricle being posterior. I'm not sure how you would get the anterior lesion, but I've seen myocardial contusions. It's usually anterior in the distribution of a diagonal vessel, and it's usually not posterior at all. So I don't know how that would play, with the seatbelt. So that's pretty shaky diagnosis. What do you do next? And so if we had a cardiac fellow that was interacting, we could talk about this, but anyone can certainly talk to us if they'd like. So if anyone would like to offer any solutions on what to do next, you can certainly speak up. And we will proceed on then. And so we have an EKG, we had an echo, we had a cardiac cath. Why don't we see what we have, and why don't we review the stuff that we got? And CT is really easy for us to do. This was in 2005 and 2004. That was really 16 slice CT days. And so, but that wasn't a problem, because if you had a slow enough heart rate, it didn't matter. You could have 8 slices or 16 slices. You get really pretty pictures. And so you could still make a nice picture. So let's take a look at that. And we have some stuff here to show you. And so let me find that. Hold on. So apparently we can't show these images. They're coming off of a DVD set, and apparently it won't play, but we'll see if we can figure out how to make this play on another computer and see if we can get this. So let's move on. So let me show you our MRI now. That was our next test. And here's our MRI. This is playing for us, so good. Let me show you this. And you'll see on this particular image, we can see the 2 areas where it's not beating well. And one area is anterior lateral, and you can see the muscle is extremely thinned, and there are some very, very deep trabeculae. And then you can see down here, just before the inferior posterior medial papillary muscle, you can see an area down here that is thinned also, and an area that's not beating well. The apex looks like it's beating well. Superior basilar, posterior basilar, all areas except these 2 little areas, which are opposite one another. One anterior lateral, the other inferior posterior mid-inferior wall. That is really interesting. Look how thin the ventricle is in those 2 sites, and look how deep the trabeculae are in those 2 areas. And you can see the mitral regurgitation is shown very well. It doesn't look like it's too severe. And that's that jet going posterior from the mitral valve. Let's see if we have some more images to show you. And here's a picture of another view showing the outflow tract of the left ventricle. The outflow tract is normal. Apex is beating normal. There's normal contractility of the posterior basilar. And we don't see those 2 areas very well in this particular view. And here's a thinned area right here with deep trabeculae. And that's the anterior lateral area. This is an apical 4-chamber type view like you see with the echocardiogram. This is the atrial septum, left atrium, a little bit generous, right atrium, right ventricle, normal contractility. The left ventricle having some area of decreased contractility in the septum, decreased contractility in the mid-inferior wall. And more images for us to flip through. We're trying to identify the areas of thinning with deep trabeculae. They're not seen in all views. There's just a hint of them on the short axis. Here's a contrast image showing myocardial perfusion, which is pretty even, except for a little bit of the septum there. More of the contrast study. This is an attempt at a look locker to null the left ventricle, and then looks for scar tissue. Again, some decrease in contractility in several areas. And this is a late gadolinium picture that basically shows that the myocardium does not have gado uptake. There's not gadolinium uptake in the myocardium, so there's no indication that there's scar tissue. And this is another view looking for late gadolinium enhancement, and we see a little bit of epicardial there in the septum. Well, it would be endocardial since there's no epicardial septum there, so it's on the right ventricular side of the septum. There's some late gadolinium enhancement, and that's it. Does anybody have any idea what we're dealing with here? Melody, can you text us if you have any idea what we're dealing with? Take a stab at it. So here's your echocardiogram. This is a TEE. I think they just did this because we're mitral regurgitation. This was done in Lakeland. It's not very helpful. Okay, Melody is suggesting carcinoid or non-compaction. Thanks, Melody. We'll keep in touch with you there. Melody's typing in since we can't talk to her. We did get a copy of the cardiac cath, and we also got a copy of the CT from 2004. We're going to try to get a whiteboard up, and I'll show you what we found. Okay, this very crude drawing is supposed to illustrate what we saw on the cardiac cath and what we saw on our CT. And it was very interesting because during diastole, the ventricle had this very peculiar shape. It had this area here that was basically very thin, had deep trabeculae, and was right before the papillary muscle. And then there was an area down here that was very thin, had deep trabeculae, and again was right before the papillary muscle. And so it actually looks like a fish with a dorsal fin and a ventral fin. And actually there is a fish called a moa or headfish that looks like that. Had just a really weird shape. We're interested in pattern recognition, and this fish is called a moa or a headfish. And as a cardiac imaging specialist, you spend about 10 years picking up 100,000 patterns. And then the second 10 years, it takes you a while. You might pick up another 20. And as you go on, it takes like 30 years to get 200,000 patterns. Meanwhile, Watson is crunching away at IBM, getting 1 billion patterns. But you see, the human mind is much more intuitive and parallels patterns in a lot of different ways. And so the first thing I thought when I saw this was the moa fish, or a giant sunfish that has these two big fins. And it looks just like that. It's really interesting. And so in terms of pattern recognition, Watson will never beat us. I know they're going to put 1 billion cardiac patterns in Watson from all these different hospitals, but I would like to challenge Watson and go up against it in cardiology. So those are my thoughts. Let's move on here, Hassan. So my goodness, this was back in 2005, and we're making a diagnosis in this lady of having isolated non-compaction of the left ventricle. Isolated means that there are no concomitant abnormalities cardiac-wise, and actually she has no other abnormalities either anywhere. And so the isolated non-compaction is a very interesting finding. You can Google that and find adults with isolated non-compaction that have survived a long time. But these two lesions are placed in two very critical places. And so they happen to be placed producing crypts just before the papillary muscle insertion, which is a very unfortunate place to place these two areas of isolated non-compaction, because it's inevitably, from looking at those diastolic pictures, going to result in remodeling, and those papillary muscles are going to lose their alignment. And as they lose their alignment, the valve gets pulled apart and becomes more and more incompetent. So mitral regurgitation begets mitral regurgitation. And so that's going to continue uninterrupted no matter what we do, because there's no treatment other than surgical for mitral regurgitation. So there's nothing we can do about that. At this time, 2005, her left atrium was 43. We had those two areas of left ventricle abnormalities. We did Holter monitors and showed she had some PVCs, but she didn't have any ventricular tachycardia, or she did not have what you call malignant arrhythmias. And so we were going to continue to treat her medically. She was on minimal dose of beta blocker, minimal ACE. And so we said, we're going to push the ACE, we're going to push the beta blocker, and see if we can make her feel better. And so, but we're going to be talking about a lady that we followed for the last 11 years and what's happened to her over these 11 years. And so that's a nice longitudinal follow-up. And if you read about non-compaction of the left ventricle, you'll find it's frequently diagnosed in children, frequently associated with children having some kind of muscular dystrophy type disease or neurological abnormalities. And so they're seen usually first by the neurologist. It's very uncommon in adults unless there are other congenital abnormalities. And so you'll find that there is a progressive history of arrhythmias, atrial and ventricular. Certainly recognize sudden death. This lady's brother died at age 54. It can be hereditary. And there are other sequelae such as mitral regurgitation, heart transplant, LVADs, all the different things that happen, congestive heart failure, that are pretty predictable. And that's what we're going to follow over this next 10 years. So her ejection fraction was 43%, RV systolic pressure of 67, mild mitral regurg, dilated right ventricle, and she was on medical therapy, and we certainly did all the imaging you can do to show what was wrong with her. Continued to push medications, and she got better, and we monitored her, and she did well until gradually her mitral valve dilated as predictable by those two lesions opposite one another, remodeling the left ventricle, increased severity of mitral regurgitation to the point where we wanted to send her for mitral valve surgery. We sent her to two surgeons to evaluate her. Actually, we didn't send her. We went, it's sort of like sending her. We went online, and we got the surgeons at their home bases, and one was at a hospital in Florida, another was a hospital in North Carolina, and she came over with her husband, and we sat right where I'm sitting now, and we put the images up just like we're doing today with the surgeon online discussing what he would do. The first surgeon wanted to do mitral valve repair. The reason why he wanted to do mitral valve repair and do a valve sparing surgery was that he had done it on two other non-compactions, and he wanted to increase his case volume so he could report them. I didn't think that was the best thing for this patient because of the malalignment of the papillary muscles. I felt like anything that he did would be reversed by the natural process that has been invoked by the non-compaction, and that he didn't offer a way of getting rid of those two trabeculate areas and incorporating them sort of into a separate fold so as to have normal muscle there. There was no compromise to that. It was just repairing the mitral valve. I didn't think that would hold up. And so we found the second surgeon who wanted to do a mitral valve replacement with a heterograft, and so we got him to do that, and that's what happened. And so she did develop post-op atrial fibrillation, had a brief period of being on amiodarone. She also had a clot in her left atrial appendage, and she had a little TIA. She put on Rhythmol, back in sinus rhythm, and improved and came home. And here's her EKG at that time, which shows dramatic changes from what you saw before. You can see this left atrium, well, the right atrium may be enlarged by this because it's pretty tall, but look how long the P wave is. You go from here to here, this is all P wave. So that means the left atrium has to be very big because that's the electrical time it takes to traverse the left atrium. So it's got to be a 16 millisecond P wave. And then you can see the QRS has gotten longer. You can see there's left anterior fascicular block because of this axis of minus 60 degrees. You can see there's a terminal conduction delay that's consistent with right bundle branch block. So we've got, a bifascicular block type situation. All of this because the heart is dilating and remodeling, and the left atrium is very enlarged. It's a normal sinus rhythm. So we can anticipate there's going to be trouble with this conduction in the future. She also had T-wave alternates testing. T-wave alternans is a way of looking for a substrate for left ventricular arrhythmias because we were always worried about sudden death. And we did come to the fact that she was having pulses, and we were having trouble with her fascicular block, which I think was probably secondary to her left ventricular remodeling and getting some fibrosis, not overall cardiomyopathy. Those non-compacted areas didn't involve the electrical system in terms of the right bundle or left bundle, but I think it was all remodeling secondary to those two areas causing the left ventricle not to contract or rest well. And so this is after she got her pacer, and we did do a bi-V pacer. You can't see a very prominent R wave up here, but you should see an R wave if it's a bi-V pacer, if we're pacing the left ventricle first and then the right ventricle. Usually we do left ventricle first, then right ventricle, usually somewhere between 20 and 40 milliseconds between them. And usually we optimize the pacer after it's been put in with an echocardiogram, looking for Vmax of the aortic valve at the same time that we're trying different intervals between LV-RV, sometimes RV-LV, and certainly P sensing. And so it is P-wave sensing, and then firing the left ventricle, we get a short PR interval by looking at where this is firing, long QRS, and it's bi-V. She just had one episode of thromboembolic events post-operative. We did have to treat her arrhythmias. She developed paroxysmal atrial flutter, atrial fibrillation again, would have severe pain, and with normal coronaries and be transported to the hospital. And we had a lot of problems with her atrial arrhythmias, finally resolved those, and then reached a point where she basically could only sit around and was class 3 but not class 4 cardiac. At that time we looked at left ventricular transplant, cardiac transplant, LVAD, and she turned both those down. She did meet with the transplant team. She said she didn't want to do that. She's very sophisticated as a nurse and understands those options thoroughly. We did put her on a drug, a new drug, that she wasn't really interested in taking. I mean, after she's been through so many medications, so many things, she was very reluctant to want to accept a new drug. But we had this new drug called Entresto, which has basically an ARB and Sabutril in it, and it's a naproxen blocker, a receptor blocker, and it's a very brand new drug on the market. And we said, let's try this on her because she meets the criteria. And so we had the medication in samples, and we lowest sample. I said, why don't you try this? And she said, no, I don't need any more drugs, but I'll take it with me. And I said, you could start it once a day instead of twice a day and see how it is, because she doesn't do well with medications. So she did go home, and a couple days later she called me and said, hey, this drug is really great. Can I take it twice a day now? And so it was remarkable that she came into the office and was walking fast and feeling very comfortable and planning a cruise. And so the fact that we elevated her B-type natriuretic peptide with this combination drug was remarkable, and then blocked the angiotensin receptors with a blocker. That combination was efficacy for her, and so we're really pleased that she did so much better. She came by the office to see us most recently during this period of being on the Entresto and feeling so much better, and this was her EKG that we got abstracted from her pacer, and she's having these salvos of ventricular tachycardia. She would get rates of 180. They were very self-limited, but dangerous looking. She'd been on many antiarrhythmics and now was still on Rhythmol, and still on a beta blocker. And because of the VTAC, even though she has an ICD, and she actually had some activation of her pacer unit where she would pace out of it and not have to use the ICD, we did transfer her to Tampa General. And so the question is, what was the origin of this? And where was it coming from? And the most likely origin that either one of us would hypothesize here at the Heart Center was that it was coming from the base of the papillary muscles where the thinned area is, and that was a macro reentry circuit. And so that's what we theorized, macro reentry. And so we sent her over for EP ablation of a ventricular focus because she couldn't go on like this. And inevitably, she's going to be shocked a few times. So she did go to Tampa General, has been there for a week. She did basically have localization of the VTAC origin because it kept recurring. They could find it at the base of the papillary muscle and did a series of ablations in that area and made it so it is non-sustainable. That is, that she could not have continuous salvos of VTAC greater than 30 seconds, which would be called sustained ventricular tachycardia. So we were able to make it through that. She's still in the hospital. She's going home in a day or two. And here she is. She gave us permission to use her picture. And she's actually, since she started on the Entresto, lost quite a bit of weight because she's become very active again. She's done the cruise. She's going to do another cruise. And if we can keep her out of the ventricular tachycardia, she should be pretty mobile. So we're talking about isolated left ventricular non-compaction, two areas where the ventricle has these deep recesses of muscle that the ventricle is endocardium, epicardium, and myocardium, and those two layers are supposed to all come together during the embryo as you develop, and in these two small areas, they didn't develop. It didn't come together. There are these deep recesses. They're in communication with the ventricular cavity, but they're not in communication with the epicardial coronary artery system. And this is not very common, as you can see. 0.014 is the occurrence, and certainly the kind we had here with these deep pockets just being in two places is extremely uncommon. And so it has to do with something intrautero occurring. It can be genetic. There are some gene mutations that have been identified. More than 10 genes have been described. And there are some other phenotypes that have been seen with other genes. And so the clinical presentation is pretty much like we've seen, except sometimes ventricular tachycardia, atrial arrhythmias, palpitations are common, dyspnea on exertion, transient ischemic attacks because of the left ventricle being dilated and being thrombogenic, sudden cardiac arrest, sudden death, perhaps like her brother at age 54. Heart failure, atrial arrhythmia. This patient actually is like poster girl for all the problems that can happen with this. The layers just don't come together. You can sometimes see it on echo. In this patient, the echo was not a very good identifier. The MRI was certainly a good identifier, and so was cardiac cath. Mitral regurgitation is not uncommon. Here's some non-compactions you can see, and I can show you an MRI of a case that we have. This is a spongiform left ventricle, and you can see it. This whole left ventricle has not compacted. We have somebody like that that's a young patient, and let me get her MRI up. Hold on, we'll get that up. Okay, so we have this case of non-compaction. Basically, you can see the entire ventricle all the way over to posterior basilar. Posterior basilar looks okay, mid-inferior wall, and then all the way around here from inferior apical, anterior lateral, lateral basilar, all is non-compacted by these deep trabeculae. And the ratio of measuring the ventricle from here to here and comparing that to the ventricle over here is usually said to be greater than 2 to 1, greater than 2 to 1 ratio during systole, greater than 2 to 1. So she meets that criteria. I don't know how this patient is doing. I just have a copy of the MRI that we did at Northside. And so again, end-diastolic non-compacted myocardial thickness are in systolic as well because it looked about the same on each ratio. So we've got end-diastolic ratio of greater than 2.3, in systolic greater than 2.0. Late gadolinium enhancement of the trabeculae, which is probably what we saw on one of those pictures that we looked at, gadolinium enhancement on the MRI. Here's a good picture of an autopsy specimen. You see the deep trabeculae. This involves this whole area here, and then you can see it compared to the normal. And the septum is compacted, and the superior basilar area is compacted, and the rest of this ventricle is non-compacted. The right ventricle appears to be compacted. Family history is very important. 3 generations of screening is very important. Unfortunately, we don't have a great deal of family, and father died of some heart event, brother died at 54 of a heart event, and so we don't have other family members to check. Outcomes are related to the severity of the non-compaction, and so someone who has greater non-compaction is going to have greater remodeling and more problems. Her problems were mostly related to all remodeling and the changes in those papillary muscles, and of course the origin of the ventricular arrhythmia. She had every complication you could possibly have. She has an ICD, she's had atrial arrhythmias, she's had mitral regurgitation, she is at risk of sudden cardiac death because of her ventricular arrhythmias. We've had a ventricular origin of her arrhythmias ablated at the base of the papillary muscles. She has an ICD, bi-V pacer in place, and responded dramatically to Entresto, turned down a heart transplant, has turned down LVAD, but is living more comfortably now, and is become from being class 3 to class 2 from being on one drug, Entresto, and her other medications. And so that's a dramatic change and a real tribute to that particular medication, preventing rehospitalizations in patients and also preventing patients from sudden death. So thank you very much for attending. I think we're going to wrap it up now. We appreciate it. I'm sorry we didn't have an interactive conference today. We'll try to get more people on mics and try to get more people called in. We'll see if we can find out what those problems are. We will be posting this online at cardiaccarecritique.com in the future. Cardiac Care Critique, cardiaccarecritique.com, where we have a posting for WFLHCA. So we'll be posting that, and we'll post the parts that we couldn't show, which were the cardiac cath and a city of the CT. So thank you, Janet, Chella, Donna, Kristen, Mary, 2 Marys, Mindy, Sandra, Sharon, Shirley, Tenva, Teresa, Michael. It was a pleasure having you today. Look forward to next week. Bye-bye.
Thanks, Dr. Harris. Great presentation. I enjoyed it. Bye now.
Bye.
Bye-bye.
Bye-bye.
And I'm going to tell you a little bit about this lady. She is 61 years old, and she presented about 5 or 6 years ago with an arrhythmia, which appears to be an AV nodal reentry tachycardia, and was found to have left ventricular dysfunction in some very interesting segmental areas, both anteriorly and inferiorly, and areas that were opposite one another, and had a cardiac catheterization, was found to have normal coronaries. She was defined as having some kind of cardiomyopathy secondary to, they said, either coronary spasm or coronary embolus, and several times subsequent to that she's had additional workups, including cardiac catheterization. She's not had any EP studies or arrhythmias. She's been on various medications and has some dyspnea on exertion and occasional chest pain, and is very concerned about her cardiac condition, doesn't really know exactly what's wrong with her and what she can do and can't do, and so this is the first CT scan that she's had. I do have her catheterization that she had several years ago, and I'd like to show that on the screen over here. So we're going to show the cardiac catheterization in the
anterior wall
RIO projection. Go ahead and speak about
So the anterior wall seems to feel like there is a sort of localized, sort of hole or cave in there, and there is no motion of that part. Especially in the
And then we're
the
looking
mid
at
part. Yeah, and also in the inferior wall, the same thing. But if I looked at that, the left ventricle, there looks, apart from these two places, pretty normal. There are some arrhythmias probably when the ventricle is, this is a normal beat, but the inferior wall does not move much. It's probably hypokinetic, that part and that part, yeah. But apart from that, I can't see much other things which are not correct.
And so she has normal coronaries
Yeah.
on this cardiac catheterization. Does that mean that she could have had a coronary embolus that divided and went to the right coronary artery and went to the diagonal simultaneously?
I don't think so.
That's pretty unlikely.
That seems
That's
very
very-
unlikely.
And do you think you'd have simultaneous spasm on two vessels,
No.
or you think she could have had spasm on one vessel and then another time
No,
spasm
no,
on another
no,
vessel,
no,
producing these blood?
I don't think so.
Okay.
No.
The next thing we entertained when we were trying to figure it out is, well, maybe she had a coup and contra coup injury from a steering wheel impaction or automobile deceleration injury that would produce opposite areas like that.
I've never seen that, to be honest. That would be the
I'm-
first case I would see. I have seen a few myocardial infarctions due to laceration of the LAD, but that's about it.
Yeah. I've never seen anything like that either.
No.
I've never seen a ventriculogram like this. Have you?
No, it's very strange that on both sides of the anterior wall and inferior wall you have that localized enlargement or whatever it is. To me it's in sort of myopathy, but I'm not sure exactly.
It's really interesting that, let me stop framing this in one position here when it fills, and it's filled during diastole.
Yeah,
It didn't stop. I stopped it here. See if I can stop. Let me stop framing this so I can show you. There we go. This pattern is very interesting because of the superior, which is like the image looks like that of there's a ocean sunfish that has this no tail, and it has a large dorsal fin and a large ventral fin, and then just a head, and it's called the headfish, and it has the same pattern as the headfish.
I like that. Yeah, maybe in our North Sea we don't see those fishes, so I'm not so familiar with them.
Yeah, we see them off the coast of California,
Right.
and it's called a headfish, and so it kind of resembles that. We can look at the ventriculogram in the other view here to see if that helps understand it. Actually, that fish in the South Pacific is called the moa moa. That's what they call that. Looks like a moa moa. In this particular view, there's some area here that doesn't seem to be as contractile again, which
so
may be looking at the same thing we were looking at before in a different view.
Yeah, because this is the thing of the biplane, the flat land, as you call
the
it.
flat land.
It always gives you not what you would like to do, but it seems, yeah,
And so then we're back
probably
to
the
there.
same thing. Yeah.
And then we can show you that the coronaries, go over here and look at the coronary arteries. Coronary arteries are stone cold normal. There's the left anterior descending, and there's a circumflex up there. There's a diagonal here, left anterior descending going down to the apex.
It's a bit tortuous,
Yes.
but that's about it.
Yeah.
But no lesions in the vessels, that's true.
Shoot through here to the right. There's the right coronary.
The right is also.
Going backwards again, get back to the heart of the matter. This Is that left ventriculogram? So we
Yeah,
decided.
so it's an abnormal left ventricle.
Yeah, so
definitely.
so we decided it's very peculiar. I've never seen in my
Yeah.
experience either, so it's very peculiar. So
But
we
then,
decided.
yeah, I looked at that, and then that's the left ventricle is so abnormal, with so many, I would say, so many holes in it. And
Yeah.
I've seen a couple of examples now, also with echocardiography. I think this is what they call, is it left ventricular impaction? Or
Yeah, non-compaction.
Of non-compaction.
Non-compaction,
Yeah,
exactly.
that's what I mean. Yeah.
And
I think this is what it is.
you're exactly on the mark. And I have never seen a case of this, and I've read
Yeah.
about it in the pediatric literature, and so I've had no knowledge whatsoever. And I always skip the articles when I'm reading because it's
Yeah.
pediatrics. And
Now, but you see them a couple of times also. I've seen a few case reports. I think one of them in circulation. That's why I
yes,
recognize it.
yes,
And also one of in heart.
yes.
So
And-
that's by, let's say, more coincidence that I just recognize it, because otherwise.
So it's a pattern
you wouldn't-
recognition.
Yeah, you
It's
wouldn't-
pattern
Yeah,
recognition.
you wouldn't know. But
And so what they do is they count the crypts, and they see these
Yeah.
deep
it's
crypts
very deep.
where there's a
Yeah.
failure of the endocardium, myocardium, and epicardium to come together
That's correct,
in the
yeah.
proper organization. And so they have these deep trabeculae, and actually the definition is by seeing how many trabeculae and counting them and so forth. And so it's called non-compaction of the
yeah.
left ventricle,
Yeah, that's right.
or it's called spongy myocardium.
That term I don't know.
Yeah, spongy
Yeah.
myocardium,
Yeah.
which is easier to remember, spongy myocardium. And there is a little left atrial enlargement on this picture as well. If you want to scroll back up a little bit, it looks like the left atrium looks a little generous there.
Let me bring it down.
Going
Yeah,
back.
but
We
that-
can measure it
that's-
over here.
yeah.
Why don't you measure it over there, Tracy?
Right about there.
Yeah. And then we can measure the wall thickness when you get to go. We can show you how you can measure this just like you do in an echocardiogram. And we got 42, and normal's up to 40, especially
Oh,
when
right,
the
okay.
valve is open.
All right,
And then
yeah.
scroll down to the ventricle and measure that posterior wall a little bit.
Yeah, that
And we'll
seems,
give you a posterior wall. It seems generous
seems
too.
normal, yeah. Or a bit-
11.5, so it's upper limit of normal. It is normal. And so then let's go back to the non-compacted areas, the best view. You had a different view where you were showing that. And so obviously then that has a diastolic and a systolic dysfunction that occurs because of that. It's been reported in the literature, there's one case in the literature that's 82 years old,
Oh,
and this lady is 61, and this
Right.
is the second, if we publish this would be the second oldest patient
all right.
that has isolated non-compaction.
Non-compaction,
It
yeah.
does occur with other congenital anomalies.
Yeah.
And in 80% of cases, at least in the pediatric literature, 80% of cases are associated with some kind of neuromuscular disorder.
Right.
And sometimes non-specific, sometimes Becker's, and all different kinds of neuromuscular disease. So the pediatric neurologist is very familiar with this. And so I called a pediatric neurologist up and said, hey, what do you know about non-compaction? And I have a patient who's 61 years old. I know it's a little bit out of your age range, but can you tell me something about what I need to do about this lady? She has no neurological symptoms or signs to my knowledge, but I'm not a neurologist and I wouldn't pick up the subtle things. And so he said, yeah, we have these patients come in with the different kinds of myopathies, maybe Duchenne's or Becker's, and what I do is eventually we pick up something going on with them in terms of congestive heart failure or something. We send them to a cardiologist, they get an echo, and then they're diagnosed as having non-compaction.
Right.
And so it comes from the neurologist first and then goes around the corner. And then a doctor or a temp general has a case that has non-compaction with Epstein's anomaly. That's someone that's 18 years old. And the next youngest case from our case would be, the next oldest case would be 25 years old in the
Right,
literature. So
okay.
there's an 82-year-old, and then our patient's 61, and then there's someone 25 in the literature. So it is compatible when it's isolated with longevity. And so I thought that was interesting that this shows it better than anything.
Yeah, absolutely.
I did an
yeah.
echocardiogram with contrast echo, and I couldn't see this kind of detail.
Oh, you couldn't see it either.
with the
But because
contrast
here
echo.
you see it almost
Which
immediately.
the literature seems to support contrast echo as the definitive way of making the diagnosis.
Yeah, yeah.
And so I thought this shows it better than anything. So that was our first mystery
and,
case for you
and
today.
the relation with the arrhythmias is probably.
Yeah, and
I haven't read about that.
there
Are you
are
sure there is?
arrhythmias that occur. This lady had a AV nodal reentry tachycardia, which I think was totally unrelated. I think she
Okay.
presented with something totally unrelated
And
because
then-
they have ventricular arrhythmias, as you would probably
Yeah,
guess,
right, yeah,
because of
because- yeah.
macro reentry circuits,
yeah.
that they would have VT. And my concern is ventricular arrhythmia, so I talked to the cardiac electrophysiologist, Dr. Herwig at Tampa General, and he suggested that we do a signal average EKG, and I don't think we're at the stage where we need to do EP testing. She did get a Holter monitor, and we didn't see any significant ventricular
Yeah,
arrhythmias.
okay.
She was a little scared to exercise, and so we put her in our cardiac rehab program for a couple classes. I don't know why she has chest pain, but obviously she could have some problems with blood flow into those areas and might get some ischemia there because of that.
And just right at those non-compaction areas, there is a very thin, or is it not
Very-
just correct?
It's very,
Because here
Yeah.
it's very thin,
it becomes
and
very
here it's
thin,
also very thin.
because it hasn't all come together
Yeah, because
in those layers.
yeah.
And so, so Dr. Illersil at non-invasive cardiology at Tampa General has a case with Epstein's that she's writing up with non-compaction.
Okay.
And so it doesn't seem to involve too much on those papillary muscles. This patient did have transesophageal echo. You can see the papillary, you can see the cords, and they don't seem to be really involved here.
Yeah.
See, they don't seem to be really involved. And so there was some mitral regurg in like the 2+ range. I consider it a high-quality study if you can see the chordae tendon there.
Oh, absolutely. Yeah, it's a beautiful.
Yeah, and so go back to the
Beautiful
chord
study,
screen and Tracy, and we'll show you the
absolutely.
chord. You can see that this is a wonderful study because you can see the papillary muscle
Yeah,
head,
there
and
you
see
have
the
it.
little
Ah,
chords, and
yeah,
so
right.
that's one of the ways I judge the quality of the study is being able to see the chords.
and the right coronary. If it's very round and sharp.
Yeah, the
then
right,
you know
the right
exactly.
coronary
This
tells
one-
you how
this
much
one was-
misregistration
Yeah,
you
yeah,
had
this one
and
was
how
really-
much motion
Yeah,
or
this
effect
started
you
to
had.
turn out nice.
Yeah.
So that's a beautiful study. So let's move on then to our next study, and that was a great case and
Yeah, that's very nice.
You made
really
it.
interesting.